Good afternoon, everyone. My name's Anne-Marie Rafferty. I have the great privilege and pleasure of being President of the Royal College of Nursing. And it's my honour to welcome you here today, so thank you for joining. We are discussing a vitally important subject today of great significance to all of us: nurses, mental health and wellbeing. Where are we now and what can we do about it? As an area of growing interest, last week we had the Health Committee's report on burnout and resilience, which demonstrated that before the pandemic even started, we had some significant and alarming levels of burnout and mental distress in nurses. C3's produced a report, Nursing Minds, that comes to similar conclusions, and at the other extreme, disconcerting levels of nurse suicide. So where are we now? What can we do about it? We've got 3 super studies to discuss today, and I'm absolutely delighted to be introducing a stellar lineup of speakers and members of our panel for you. So first up today will be Professor Sir Simon Wesley, who is Regius Professor of Psychiatry at King's College London, and for our purposes today, also the principal investigator of NHS CHECK study, which he'll be discussing and sharing with us shortly. So welcome, Simon. We also have Dr. Keith Cooper, who's an assistant professor from the University of Warwick, a clinical academic, also working in University of Birmingham hospitals, an expert in intensive care and dealing with such scary subjects as research into cardiac arrest. So welcome, Keith. Our third speaker is Dr. Juliana Onumere, who is a senior lecturer and clinical consultant psychologist at King's College London, and a key member of the TIDES, which is a subset study of the NHS CHECK, and I'm sure that Juliana will enlighten us on what the TIDES acronym stands for, and similarly Keith will about the ICON study. Joining our panel to field some of your questions is Dr. Mary Docherty, who is a consultant liaison psychiatrist at South London, the Maudsley NHS Foundation Trust. She's also Deputy Medical Director there. And her special role and expertise today is that she actually led the design and development of the initial psychological support programme for staff at King's College Hospital Foundation Trust. And finally, we have Laura Duffel, who is also from KCH Foundation Trust. Laura was a matron in paediatrics until she transitioned into leading the staff wellbeing and mental health support programme at King's College London. So I can't think of a better panel to be really tackling this vitally important subject today. I also want to just thank, before we go into Simon's presentation, people who've been making this possible behind the scenes. Lindsay Chalfant, who is our events organiser, one of them anyway, from the RCN. I want to thank Lindsay, Rob Castro on IT and AV, Christine Callender, and Stephen Jones, who is a professional lead for mental health, Christine, Head of Nursing Quality from the Nursing Department at RCN, and last but not least, Rosie Duncan, who is working behind the scenes on helping to moderate some of the questions. So without any further ado, I'll just hand over to Simon to kick us off with his presentation. Thanks, Simon.
Great, thank you very much, Anne-Marie. Very nice to be here. And like you, I was going to start with the report from the Select Committee a few days ago. To be honest, whenever one talks on this subject, there's always been a report in the last few hours saying just how terrible is the mental health of the NHS workforce. And also, as indeed Anne-Marie just mentioned, that's been the case for many years. Didn't start with COVID and it won't end with COVID. This has always been a workforce with higher rates of mental distress than many other workforces, with high rates of staff turnover and high rates of sick leave, which is a very good indicator of well-being. And now, of course, all these stories come out even more often than they did before, and all of them attribute everything to COVID. So the first thing to say is things were not rosy before all this started. We were not in a great place already. 30% of staff, depending on how you looked at it, seemed to have symptoms indicative of mental disorder. So the question is not what has caused this, it is has COVID made it any worse? So could we move on to the next one, Rob? Thanks very much. So this is the study we've done, NHS CHECK, and another one. And we've got, move on again, Rob, please. Yeah, thanks very much. So this is, in fact, the biggest study that we've had so far. We would say that, wouldn't we? But it is true. So that started rather shambolically, much like our reaction to everything around COVID did at the beginning of March last year, but actually picked up speed fairly soon. And the only reason for paying any attention to this is because this is one of the few such studies. Indeed, it might even be the only one. There are millions of these studies and surveys. I promise you, I'm actually, in my other life, I'm a clinical psychiatrist, but I'm actually an epidemiologist. And this is the kind of stuff I do for a living. And about the only great thing about the pandemic is I don't have to explain what epidemiology is anymore, because most of the population and every single journalist think they are one. But it's that our population is all the staff of the 18 trusts that have taken part. Doesn't mean we can find them all, but at least we know who they are, and that's a good start. So off we go then. Let's move on to I hope is going to be some of the results from the next one, please, Rob. And so first of all, as you can see, we just had a look here at the demographics to particularly look to see in the nurses in the sample, how do they correspond to what we know about the demographics of the NHS. And what we find is the NHS is, of course, more female than male, and so is our survey, just a little bit higher than the baselines. That's because females are more likely to answer surveys than males. Ditto with those from an ethnic minority. Again, the same reason. All studies always done. You always get fewer responses or less responses. No, it's fewer, isn't it? Fewer responses from those of an ethnic minority background. So it's reasonably representative, but has some of the biases that all studies of NHS workforce always has. What it also has is what looks like a dreadful response rate, 7%, 17%, which is a dreadful response rate. However, and I speak as someone who, as I say, does this for a living, and I do studies with the British Army, which is about as hard as you can get. And there we would normally get 60 or 70%. And in primary care studies a few years ago, we would normally get 90%. And here you can see this is very poor. It's about the best we have going, though. Another London teaching hospital study has 0.5%, but even that's not the worst. The worst was the Royal College of Surgeons, who did a study or invited people from the whole of the NHS to take part in their study, again, of health and well-being. They had 800 responses, which sounds very, very good, until you remember 1.4 million people work in the NHS. So that's a response rate of 0.00005, which we believe is actually a world record. So well done, surgeons. So next one, please. Okay, so what we can see straight away from here is we're just looking, there's all the trusts that have taken part on the left. And what we can see is if we look at the results, you can see over half of the people who've taken part in NHS CHECK seem to be having symptoms that could suggest what we call a common mental disorder, which is basically depression or anxiety. Common in the population, but 53% is high for any population. Lower levels, but still high for anxiety and depression. And alcohol misuse, actually, well, it's the one thing we have which is lower than the British Army, but that's not saying anything. 12% is actually probably slightly lower than you would have in a normal population. PTSD, 24%, much higher, considerably higher. And this new concept of people who've been put into very difficult moral situations. We call it moral injury. We picked this up from the military. It's been asking you to do something that you feel isn't right, basically wrong. And in this context, it's been asking you to give care when you don't feel you have the right equipment or the right staff or the right training, where you would have been able to deliver better care last year and you expect to deliver better care next year, and now you can't. And this is sometimes referred to as a moral injury. It's not a psychiatric disorder, but it can lead to it. And you can see that nearly everybody reported being put into these kind of situations during the pandemic. Now, if you look on the right, those are the figures for nurses, and you can see that they're very, very similar to the overall survey. Now, that's quite simply for a statistical reason, because nurses make up the biggest portion of the workforce. So you would expect them to be closer to the mean than any other group. If this was replaced by doctors, sad to say for you, you would find that all those levels would be lower, apart from the drinking, but all the others would be lower if we just looked at a different sector, which would be the medical workforce, which has done better. Next one, please. Now, and then this is almost the other way around, is to say, what we've actually said, what are the things that seem to protect you against having worse outcomes? And in a nutshell, basically, the answer is being me. So being older, being male, being a doctor, and no longer being frontline, and also not coming from an ethnic minority. So basically, the answer is it's better to be me than to be most of the people watching this webinar. And that, of course, is nothing to do with the NHS. That's the standard socio-demographics of distress in this country. It's better to have a better paid job. It's better to be male. It's better to be older. Better not to be in very frontline jobs. I'm mainly a research and academic, and I've not been able to do much clinical during this period. And obviously I'm not part of an ethnic minority. So these figures reflect what we already knew, suggest that the study, even though it's got this response rate problem, it's still not giving us a distorted answer, because if it gave us any other answer than this, we would worry. Next one, please. Now, just a bit of context. Now this is why I don't normally use PowerPoint. This is what we call a busy slide, but this is just to compare with what do we know. Well, first of all, we know that these are higher than we would expect in the normal population, point number one. Now, no shit Sherlock, you would say at this point, because of course, everybody in the NHS, just like everyone in the population, has been exposed to the stresses of the pandemic. And just because you work in the NHS doesn't mean that you have no children at school, or i.e. no children not at school, doesn't mean that your social life has not been completely wrecked by the pandemic, doesn't mean that you're frightened and fearful of actually getting the infection itself. Of course it doesn't. If anything, you're more likely to be than less. So the population mental health has deteriorated, that's a fact, and therefore so will the NHS workforce. The question is, has it deteriorated more than in the rest of the population? And that's slightly confusing, because some of the studies, one of them being ours, suggest no, other studies suggest yes. So we're not entirely sure if this effect is the COVID effect reflected across the country or a specific one to the NHS. It's not entirely sure. And part of that is a kind of methodological issue, which I'll finish up with just in a minute. Next one. Thanks. Now, what about support? Now, I find this actually quite interesting, because we've just shown you, or I've just shown you, I use the raw we there, but I've just shown you all that data suggesting that things aren't good. High rates of depression, high rates of stress, more than half have common mental health problems. A quarter have PTSD. But at the same time, people are also reporting high levels of support. So you can see there, both for the sample and for nurses, 3/4 feel that they've had from extremely to quite a bit of support from their colleagues. Jump to the bottom, you will find even more feel that they've had quite a bit to quite a lot of support from their family. And then even in the middle, still the majority say they've had quite a bit of support from supervisors and managers. And you might think, well, that's a bit surprising, but actually, no, it isn't. These are the normal sources of support we have in our lives. They haven't stopped during the pandemic. Always, but always, the best way of getting through difficulties is to have friends, family and colleagues, not necessarily in that order, but in some order. And then next, most important, are the people you report to, your supervisors and managers. So people are reporting quite high levels of support, despite also feeling overworked, stressed, burnt out, distressed, etc., etc. These two are not incompatible, but this bit is the bit that gives one confidence that as conditions improve, so will mental health. And this reminds you of just where most of our support comes from. It is from our friends, our families and colleagues, not people like me. And I'll end up with that, and just reminding you that the people you don't want to see straight away off the top are people like me. We also haven't put this up yet, the data up yet, but also a lot of people also reported that they'd gained from the epidemic as well. They'd found that they were able to cope with stress better than they thought. They could do more than they thought. They now belong to a team which they didn't think possible before. So it's not all been bad. Many people say, now that I've weathered this, I can probably cope with anything that life throws at me after all this is over. Rather similar to our soldiers when they come back from deployment. I'm not saying that you are soldiers who've deployed, but there are some similarities in an extreme experience that it's bad, but also some good can come out of it as well. Next one, near the end now. Right, now then, this is about what support do people get or look for. Now remember, it's what they look for. And what you can see is a third of the people, a third of nurses, a third of people have gone and looked for some help. First of all, the biggest issue one they'd go for is those that are around them. So homegrown things going on in the trusts where they work. And I mean, we put one wellbeing activity, mindfulness, but basically we think there's about 70 different programs running across the 18 trusts that are part of this study. And you can see that's where most people have turned to most of the time, relaxation areas, etc., etc. And the list is nearly endless. Now, but we then see much lower people have, fewer people have resorted to external sources of support. So they've either used helplines, just 1 in 10, or gone to external counselling, again 1 in 10, which is actually much higher than I was expecting, because if you look at the numbers who have gone, it's not very many if you look at the EAP program. So this is actually does suggest an increase, but it's still not very many. Most people prefer homegrown things. And then if you look at the others, you see much lower rates. I think that's because many of these things are actually not, only a few have actually got access to things that you can't volunteer for, that you either have them or you don't. Organizational support such as check-ins, debriefs, supervision, things like that, which have been classically bad across the NHS anyway. So those figures, I think, reflect those who actually have access to them. Next one. Right, now what about the study? Well, you'd expect me as a boring boffin to point to the good bits, and the good bits of this are that it is big, it is representative, it does cover all the different grades, all the different professionals, all the different demographics within the NHS. And I think there's only 2 other studies that have done that. Most have been on, ITU or this, or nurses or doctors, whatever. But we've looked at all employees at 18 trusts. Obviously, the limitation is that it's self-report, measures, questionnaires, and just to say, we are now interviewing people, and the best way to determine, in fact, finally the only way, the gold standard, is to go and do actual interviews. And we are finding, as we suspected, that questionnaires exaggerate distress and disorder. That's been known for as long as I've been doing this kind of work. So those questionnaire results should be taken as a slight pinch of salt. They're a screening measure, but the definitive test is the interview. I do not think, in fact, we know that it is not going to be the case that 1 in 4 of NHS employees have post-traumatic stress disorder, a severe disorder that will require treatment, because those rates are much higher than we found in any other study that we've done. And we've done a lot of studies on PTSD in different situations. Next one, I think it might be final one. Okay, so what are we doing next? Okay, well, first of all, we are now doing, as I've said, diagnostic interviews, well underway with that. We're also going to follow you up. If you logged in because you were part of this study, please bear with us. Do please help. If you're getting a reminder to say, would you please contribute your data, please fill in a form, please do so. Because the other thing, because we went to all the trouble to get ethics approval, proper consent, all of that stuff, is so that we can follow people up. And the most important thing is, as you know, we're not quite out of the woods yet, but we're getting there. And as the situation improves, we will predict that, you know, a lot of this is situational. And as the situation improves, many people will start to feel a bit better. That's what we hope. But please, please, please do take part. We're also doing a randomized controlled trial. I mean, there are apps everywhere. I have no idea how many NHS apps there are. I have literally no idea. But only one of them will be part of a randomized trial. And that's ours. It's not our app, but we're testing out a popular well-being app, randomizing people. Again, if you're in the study, you'll either have been given this or you won't. And this is to see, do they do what they say on the tin? It'd be great if they did, because they're easy to use and very cheap. We shall see. And then we're talking to people in more depth about lots of issues as well. So I'm going to stop there because my time is well up, and I'm going to leave you there. I am going to have to go very shortly because I've double booked due to a terrible error, basically, and I've got to get to Cambridge. But the others will still be around, and plenty of time for questions. So if you have been listening, thank you very much.
That's brilliant. So much time. I just wanted to rectify a little lapse that I made at the beginning, which was not to remind you to pop your questions in any time for any of the presentations into the Q&A, which is, you know, rather important if we want to have questions. We've got Keith up next before Juliana, but I just wanted to also say that if you need live captioning, that's on the right bottom hand of your screen. Please press that, and I can remind you about any other questions for follow-up, and the NHS CHECK at kcl.ac.uk address. Hopefully I'll remember that at the end in the evaluation. So naughty Anne-Marie for forgetting those things, but Simon, thanks very much. And I'm going to hand over now to Keith. Keith, the floor is yours. Thanks.
Perfect. So thank you very much for the introduction and the opportunity to talk today. Many of you may have realised from the introduction you had at the beginning that I am something of an interloper here. I'm surrounded by people with expertise in this area, whereas my life is focused predominantly on the critically ill patient and research around cardiac arrest. So my task over the next 10 minutes is hopefully to provide an overview of the study that I was involved in, called The Impact of COVID-19 on the UK Nursing and Midwifery Workforce. And there are some similarities to what Simon has just described in terms of what we did, but there are also some distinct differences. So I'm going to hope to try and cover those. So I think we need to be mindful of what was happening in the first quarter of 2020. We were obviously very aware of what was happening throughout the world, particularly in China and northern Italy. Images such as this were very prevalent across the media. In the UK, we had modelling work that was showing the dramatic likely impact of COVID on our healthcare system. And I think what these images don't convey very well is how the pandemic might impact on staff that were working within these challenging situations. We also saw much focus on the hospital setting, neglecting the challenges of those working in other settings such as primary and social care. And as Simon alluded to in the previous presentation, prior to COVID-19, of course, we already had a nursing and midwifery workforce under intense pressure. We had widespread workforce shortages and high attrition, and we were already working under significant pressure. So that's really the context of what happened next. So as a member of the Royal College of Nursing Research Forum Steering Committee, I identified relatively early on the fact that there was probably a need to measure this and to understand what was going on. So on this slide here, you'll see, first of all, the unifying force of the Royal College of Nursing, but also the organisations to which members of the ICON team came. And we were delighted to have such an amazing team, of which I was very much the weak point in terms of expertise and knowledge. So what we then did was we had the ICON study, and this is what we set out to do. We set out to explore the impact of the COVID-19 pandemic on frontline nursing staff psychological health potentially as a way to understand it and potentially as a way to help aid their long-term recovery. That was very much in the back of our mind. And what we had was a complementary survey and a qualitative work stream. So in terms of what we had in the survey, we had a free time point online survey. We'd planned, and we'll come back to that in a second, that we'd undertake the first survey prior to the peak of the pandemic. The second survey would happen during the peak of the pandemic, and the third survey would happen during a recovery period, which we defined as 3 months following the first peak. We wanted to include all UK nursing and midwifery workforce members. This was not just about people working in acute hospitals. This was not just about people working within the NHS. This was about the whole UK nursing and midwifery workforce, including healthcare assistants, student nurses, nursing associates, and all those other key members that contribute to the care that we deliver. And we were also aware that there was a Royal College of Emergency Medicine survey that was happening around the same time, and that was targeted at doctors in emergency medicine, anaesthesia and intensive care medicine, and we sought to align some of our survey with what they were doing. A qualitative study, which was led by the team at Surrey University, particularly Anna Connolly, Ruth Abrams and Jill Mabon. That was a longitudinal interview study. I've put the numbers there, but we'll come back to that shortly. But the key thing really is that we used survey respondents who'd opted in to be interviewed, and we aimed to sample those for diversity. And we got an incredible range of individuals who kindly participated to that. I put this slide up simply to try and show that the challenge that we faced and the rapidity of what we tried to do in terms of setting up the study. So we moved from day 0 having a first concept to day 12 having our first survey disseminated. One of the key things that we were keen to try and do was to distribute our results as quickly as we possibly could, because we had a feeling that our findings may help to influence our pandemic response, particularly when we find issues around PPE or the challenges that individuals are facing. And we were delighted that early survey data was covered by both specialist and general media, and information from our qualitative work fed into the report that Anne-Marie mentioned at the beginning on workforce burnout and resilience in the NHS. So this is what our survey did. We had 3 time points. You'll see here where I've put the time points at the top and tried to correlate those to the number of hospitalised COVID-19 patients. And admittedly, there's many different ways of measuring the impact of a pandemic. This is potentially a one that's relatively easy to measure. It may not be the best, but you'll see here that actually our time point 1 survey, if you look at the national picture, did cross the peak of the survey, whereas our time point 2 was quite shortly afterwards, but probably providing an ideal opportunity for people to start reflect in their answers on what was really happening during the peak. And it's certainly not to say that at time point 2 things were not still incredibly challenging. There was still a high number of hospitalised patients, there was still a high number of deaths happening on a daily basis, and there was still a high number of patients in intensive care, and obviously the patients within the social care sector as well. Simon described the cohort that they recruited. Our cohort was not too dissimilar from that. 92% of our respondents were female, 90% described their ethnicity as white, 77% were registered nurses looking after adults, 3/4 were employed by the NHS, and then 29%, and this is one of the potentially important things that you can look at in a survey dedicated to nursing and midwives, is around the redeployment, and we found that almost 1/3 of our respondents were redeployed. So on this slide, I'm just going to show some of, very few, but some of our findings and the data that we found across all 3 surveys. It's difficult to provide the granularity of how things changed, but there's certainly changes over time in what people were reporting. But when we look at this, we can see that people often agreed or strongly agreed that their health was at risk due to their clinical role during the pandemic. People considered that correct PPE was only available around 50 to 55% of respondents. That's a really important gap there in terms of the people who felt that the correct PPE was not always available to them. And whilst that declined over the 3 time points, it was still an important proportion even at the end. And it was very similar in relation to the confidence in infection prevention and control training that was provided to individuals. People often felt not adequately prepared to give care to COVID-19 patients. And finally, here at the end, you can see that overall, around 19% of people were redeployed with no or inadequate training. When you look at that in terms of the proportion that were actually redeployed, it ends up being about 2/3 that felt they had no or inadequate training in terms of that redeployment. And that's incredibly challenging. So we use the impact of event scale to look at some of our outcomes, and you'll see here we need to be obviously very wary of interpreting what's going on here in terms of a score on the impact of event scale does not correlate to a PTSD diagnosis, but it certainly provides some areas for concern. We can certainly see a decline here going on over our 3 survey time points, but even at the end, it strikes me that there's still a worrying number. And I mentioned earlier on that there was another survey that was going on that was looking at intensive care medicine, anaesthesia and emergency medicine doctors. When you plot their data against ours, you can see that difference that Simon really was mentioning in terms of the difference in prevalence of this particular score and the potential implications of that. When we look at some of our other outcomes, you'll see similarly there was a reduction in severe, extremely severe anxiety and stress across the survey time points. But what is perhaps more striking is this proportion of people who are very or somewhat dissatisfied with their job. People really found the pandemic challenging, and that's probably reflected in this. I'm going to move on now to briefly mention some of the things that we identified in our qualitative work. As I said, that was led by the University of Surrey and under Jill Mabin's expert leadership. People were reporting a roller coaster experiences. Things were changing on a daily basis. They were having to adapt to new ways of working. Moral distress was a constant theme. People were unable to deliver their usual high standards of care, constant care delivery challenges, high death rates, difficulties in terms of personal protective equipment, and often this concept of work being left undone. There was talk around the effect of the organisational response and the adequacy of staffing, leadership and personal protective equipment. And perhaps importantly that we found from this, because we were able to interview on 2 occasions, people found the second wave was harder. Whether that was due to exhaustion or shift in public opinion, that's not entirely clear. Simon's already spoken about the support and the way that people access it. Our interviewees spoke about the national offer, and often people were somewhat wary of accessing that national offer. What they found incredibly valuable, albeit we don't know how clinically effective it might be, is around the value of sharing with colleagues who've been through the same thing, whether that was at work or through virtual groups. So I'm going to finish with this slide and the conclusion, and I guess the key theme here is that the nurses and midwives that work through the pandemic are not superheroes. It seems that there's probably been an important impact on their lives and so psychological well-being. The effects aren't over, but we don't know what's going to happen next. Certainly people have described sharing experiences and the value of sharing experiences with colleagues who've been through the same thing. I think the key thing here is we need high level evidence, which it's great that Simon is starting to produce, around what support is going to be effective and accessible. So finally, I'd like to thank the Burdett Trust for Nursing and Florence Nightingale Foundation, who funded part of the work, the collaborators, but perhaps most importantly of all, the many individuals that participated both to the survey and to the interviews. And with that, I'd hand back to Anne-Marie.
Thanks very much, Keith. That's brilliant, and I think complements a lot of what Simon was saying as well. So nice to have that dovetailing there. Let's move on immediately then, without any further ado, to Juliana's presentation. So just now like to hand over to Juliana and wait for your slides to be loaded up as well. Thanks, Juliana.
Thanks, Anne. And let's go. So welcome everybody, and as Anne said, I'm Juliana. So what is the TIDES about? What does it stand for? So the TIDES study aims to understand how discrimination, and certainly witnessed or experienced by healthcare practitioners, is related to work and health outcomes, and how this may contribute to inequalities in health services. But some of you might be sitting there thinking, but how does this relate to what we've heard from Keith and Simon? So part of the work I'm going to focus on today is a partnership with us in terms of between TIDES and the NHS CHECK study as well. So just a bit of background, which may well be familiar to some of you, but also might be news to many. We know that the NHS is one of the largest, if not the largest, employer of minority ethnic staff, certainly within England. And, you know, in terms of different types of data sources, minority ethnic staff will comprise at least, 20% of the workforce. But sadly, we also know that ethnic minority staff, that they tend to be those groups that are more likely actually to experience greater levels of workplace harassment and discrimination, certainly when compared to other groups of staff. And again, sadly for us all, discrimination, certainly reports of harassment, have actually been on the rise, have been increasing over the last 5 years. And also ethnic minority staff do typically report poorer working conditions. And by that, in terms of just their experiences in the workplace, but equally do tend to feel more disempowered in terms of how to address them and seek a helpful resolution. So some earlier work from TIDES, just to contextualise the work that I'm going to talk about, is in terms of some of their earlier work and their phase 1 work. This is a really nice study that just investigated more broadly how discrimination experienced by actually patients or service users, as people might describe them, and healthcare practitioners, how that might also be generated but also perpetuate inequalities that have been reported in health service use. When we've done a bit more of a deeper dive into those groups that are reporting these experiences, there are particular groups within that, particular subpopulations within that, who tend to report higher levels. And that tends to be females, women, Black ethnic groups, and also those identified or described as migrant groups, as they're the ones who are more likely to experience or indeed witness discrimination and harassment in the workplace. You've heard earlier from both of our earlier speakers just in terms of the sort of occupational implications for just, poor well-being. We know actually that exposure to discrimination and harassment, certainly from this early phase work, is associated with poor physical and mental health of all those types of outcomes. But actually, more importantly for us, certainly within the employment setting, it's also related to people reporting lower job satisfaction. And that's a worry, given that we spend a lot of our time in the workspace, but also longer periods of sickness. And any of us that work in clinically, longer periods of sickness can have an impact just on not just the service, but also what we were able to do. So as part of that work, in terms of the phase 1 work, interviews were undertaken with a really mixed group, generally within healthcare, including nurses, healthcare assistants, and also at different levels, so including some senior staff as well. And the sort of message really was where incidents of discrimination tended to arise, and certainly within the workforce of the workplace, these tended to sort of coalesce around or attributed to people's race or ethnicity. Other contributing factors, which was really important, included unfair disciplinaries or negative work appraisals. Again, very much linked to or attributed to someone's race or ethnicity, and clearly also linked to more sort of negative stereotypes. Again, what was important for us is just to think about that many of the staff that are kind of reporting these experiences often actually felt quite resigned to these everyday, if one describes them as that, everyday discriminations, and sort of brushing it off and carrying on. And also many people feeling like actually the best course of action was to kind of move on, to resign, move on, get another job, rather than, I guess, fight your corner at that time. So why? I just want to give you a bit of brief background because to take us to where we are today. So the phase 2 of the TIDE study is very much using different mixed methods to really kind of identify and focus a bit more on ethnic inequalities in, again, mental health and work outcomes amongst the NHS staff who've been impacted by COVID-19. And so this was a great opportunity. So I would actually go back. Simon talked about his strengths and weaknesses. I think it's a fabulous strength of the NHS CHECK study in terms of this partnership to really kind of think ahead about actually subgroups within the people that they might be sampling. So the focus of the TIDES 2 was to produce and develop an inequality survey as part of the NHS CHECK, and therefore being able to sample many of those people that are part of those 18 trusts who are involved in the broader study, just to kind of think about what those issues might be. And this would involve, and it does involve, undertaking interviews, also with our NHS CHECK participants. And I'll talk a bit later about what we want to get out of that as well. Some of you might have questions in terms of, you know, inequality survey, NHS CHECK, what does that mean? What it means is wanting to ask key questions, but how did we arrive at those key questions? What did we see as a priority? Well, it wasn't certainly something that came up as part of the team on its own. This was very much an outcome of a lot of work around consensus building, and that's actually thinking and working and getting ideas from key stakeholders within the communities and key stakeholders actually within important organisations that we work with, including those in nursing and in our other professional groups as well. And this sat on the back of reviewing evidence and helping, you know, all of our stakeholders helping us to understand and prioritise what would be the key questions to ask about as part of these surveys. As part of the inequality survey, which is kind of nested within the broader NHS study, we're asking questions about risk assessments, redeployment. I mean, you heard Keith just talking earlier about that in relation to their work, but also just the you know, questions around working from home, the PPE, on top of questions around discrimination, and also people who working but also with long-standing illness. And you know, much of the conversations today is about support, but workplace support, and also the big questions around COVID and vaccines. And you know, fundamentally, what does it try and do? What is it trying to do in addition to or alongside the broader NHS CHECK? What it's helping us to do and what it will allow us to do is to understand a bit more about the inequalities of racial and ethnic minority groups within the NHS, but also now within the context of the pandemic. We have the pre-pandemic data, but to understand what's actually happened in this time period that we've all been focused on. So just the last bit I just want to focus on is just remind people, so you know, TIDES was going on prior to the pandemic and had looked at healthcare professionals prior to the pandemic. So part of the work now has also just been following up those healthcare professionals in addition to what we will get from the health inequalities. But I want to pick this up because it you know, it would be relevant and should be relevant to us all. So this is some follow-up work that we've done in terms of some of the healthcare professionals that we had interviewed before the pandemic and now interviewed them afterwards, and also supplemented by senior members of staff. And this is very much a study focused on vaccines. So we know, so in terms of based on their qualitative interviews, and perhaps what people might even see anecdotally, that the decision to take up an offer of a vaccine may not always be that simple and straightforward for any group, irrespective of their background. But amongst racial and ethnic minority groups, we found that it's definitely around balancing up a number of factors. And these are weighing up the risk and benefits, not just to yourself, but also to others. And the decision to, you know, to take up a vaccine takes into account, you know, your beliefs about protecting yourself, protecting others, protecting the people that you work or care for in terms of patients, and being part of that sort of overall big effort to kind of, you know, make society healthy or safer. But that's also balanced with real concerns for some around fear of harm to self, and mistrust actually in organisations, and also not divorced from wider issues around discrimination. And that could be perceptions of, or indeed lived experiences of discrimination. So these are the types of factors that are influencing individual decisions around vaccine uptake, and this seems to be particularly relevant based on qualitative data that we have, and particularly relevant amongst our racial and ethnic minority healthcare staff. I'll just finally just end on some of these examples. I won't read them out entirely, but just to give you a bit of a sense in terms of the key factors that were coming up. So racial injustices in vaccine development, that seemed to be a really particular a theme for healthcare professionals. And someone said here, you know, because we've been, you know, historically and politically used as guinea pigs for all sorts of things and harmed historically in the US and here and whatever, you know, it's a real sense that, you know, not trusting in practices and people's sort of safe healthcare for minority groups, and that kind of feeds into people's concerns or indeed hesitancy around taking up offers of vaccines. But also for some people, and particularly in the religious and ethnic minority or racial and ethnic minority groups, just concerned, you know, decisions being very much impacted or influenced to some degree around sort of on religious or ethical concerns. And more importantly, or not necessarily more importantly, but relevant, I guess, today, given some of the media reports that we've seen, is, you know, healthcare staff being concerned, and certainly our racial and ethnic minority staff being concerned about what they perceive as potential pressures from organisations in order to make their decisions around vaccines. So some people have put here, you know, because people from, you know, BME backgrounds have been identified as being as higher risk, they could potentially also be more pressured into getting it or getting the vaccine. So it's really important in terms of, I guess, one of the things that's certainly getting us thinking about that people's ideas and people's decision making about healthcare as a healthcare worker and about vaccines as a healthcare worker, but particularly as a racial and ethnic minority worker, is not divorced from broader issues going on in society, and particularly those that relate to discrimination or perceived reports of. This is all very well. Obviously, I could speak for the entire day about these types of experiences, but what most people tend to ask us is, you know, but what's this going to be about? What are we going to try and do with it? So at the moment, the data is still ongoing in terms of collecting data, but what we would like to be doing, what we'll be focusing on, is being able to kind of pull different phases of our data collection together to very much support the development of something quite practical. Don't be tied to this title, but certainly a race equality toolkit to kind of support organisations about how to develop and support racial and ethnic minority groups within their organisations, but all groups, to kind of have to feel like the workplace is a fair place for everybody, but also to augment that type of work with some practical training. And so our work will be focused on development of virtual reality training materials. And just the usual bits that we do at the end. If you do want some more information about this, you can catch this from the TIDE study data, the websites, and, you know, follow us on social media. And that's the end.
Lovely, thank you so much, Juliana. That's a really comprehensive run through the study. We've got a few minutes for questions, and I'm just going to move directly into those. So there's a question here that I'd like to put to Laura, actually, since she's working very much on the ground. And it does link to this broader question of signposting staff towards support. And it is, where can I access help if I feel overwhelmed at work? How do you sort of signpost staff and get them into the conversation about support. And now people may come to you directly, or you may have to seek them out. So I'd love your views on that, Laura. Thanks.
Thanks, Anne-Marie. Yeah, so we are very much trying to engage with staff, not just on a one-to-one basis in our wellbeing hubs, but also within team meetings and visiting wards on a day-to-day basis. So I think that having a wellbeing conversation with somebody and just checking in with them to see how they're getting on, and just to signpost them, just to say that if there is a conversation that they want to have away from work, there are resources in various places online. For example, in South East London, there is an amazing website, Keeping Well, in South East London, and as well as the practitioner health website, which people can access as well. So I would always encourage people to speak to managers if they feel comfortable doing so, because managers are the first point of access for staff and are there to provide support to their staff, as well as their peers. So we are trying to encourage teamwork. We think wellbeing champions in different areas, whether it's clinical or non-clinical, is vital. So people that are able to spend time making sure resources are up to date in their areas, potentially having a wellbeing notice board where people can put information up so that people can access that confidentially if they feel that's better for them. But yeah, I think the main thing I would say is, if anyone is feeling that they just want to have a conversation, they're feeling a little bit anxious, a little bit stressed, just seek out somebody that they feel comfortable speaking to. It's online through chat functions, or meeting somebody at work. So I hope that helps.
That's great, Laura. It sounds as if that ties in quite neatly with what Juliana was talking about in terms of, trust being quite an important factor here in terms of accessing resources. We've got another question here, maybe it's one for Mary, which is, if I seek help for my mental health, could I lose my registration?
Thanks, Anne-Marie. I think the way I'd respond to that would be to say the highest risk you have of losing your registration is to not seek support for your mental health. We know very clearly that there's an association between clinical errors and lower quality patient care for people who haven't got support for untreated depression or anxiety or from burnout. There are some mild exceptions, which is if there's a concern about immediate harm to you or others, then appropriate processes would be followed, but that comes so rarely, and you would never not be involved in that conversation. So I always think it's just park that thinking. The thinking that you should have is, what is the risk if I don't seek support? And for example, practitioner health, which Laura just mentioned, this is a brilliant service. It was originally set up for doctors, but as Simon said, we've got a lot of support, and it's now been extended to the rest of the NHS. And it's an entirely confidential service. There's an agreement with regulators, and it's a completely safe place to explore whether it's a mental health condition, a substance misuse condition. So I would implore people to park that sort of thinking. That's years and years of stigma and us not getting the message out properly. If you are struggling, you need to get help. That's the way to look after you and to look after your patients.
Thanks, Mary. That sounds fantastic. Maybe one for Keith now. What are some of the challenges in ensuring that the COVID wellbeing fad is actually sustained beyond the COVID period? It's sustained in a kind of authentic and meaningful manner, that it has a kind of afterlife, if you like, and legacy. Keith, thoughts on that?
So as I described in my talk, I'm the interloper here. I guess from a frontline perspective, it's one of these challenges. We go back to, at some point, hopefully some degree of normal, how we potentially sustain the lessons we've learned about well-being at work into that new period. I'm not sure there's an easy answer to that. I think there's a lot here about doing a lot of work with the people who want to access that help to understand what they need and when they need it. And I think getting really good evidence as to what we know works or what doesn't work really should help to guide what's offered to people. But also we need to understand how and when they want it. And I think that's the incredibly challenging thing to determine.
Thanks, Keith. Mary, do you want to come in there as well?
Yes, just a couple of other points. I mean, I think Keith covered it really well. It's first of all, it's the evidence, but then I think there's also, we need to pay for it. We need to prioritise it. And the key risk for me, it's the left and the right hand doing different things. So I'll give you an example of, we're just at the end of the first surge. I just spent an hour doing a reflective practice group with some nursing staff. The sort of things that we're going through is unbelievable. And then in the sort of the same conversation, 5 minutes later, they get an aggressive response about a day ticks for a patient who'd fallen. And this is, to me, one of the problems, that if we just think we're going to buy in some well-being stuff and put that there, but we don't systemically wrap this through policies and procedures and how we do things in an organisation, how we communicate with our staff, that's where I think things will become, cynicism will set in. They'll think, well, you know, you can keep your mindfulness because actually you're not consistently treating me like a hardworking human being who cares. So I think that's the thing for me. It's thinking about the structures, the processes and the leadership within an organisation. How do we ensure that well-being is not some stuff that's just done, that's woven in through operational policies throughout an organisation and says that this is something that's important. I think the final point I'll make to that is something that devastated me in the first wave was our nursing staff being so overwhelmed that someone had maybe given them a room where they could have a cup of tea. You know, and that's outrageous. It's just absolute basic. And the fact that they were so grateful that we'd said, actually, it's important that we set an hour aside a week to think about how your work's impacting on you. Like, if that's not acceptable, that we think that that's, you know, that's a treat, that should be the absolute norm. So I think it's about us saying our expectations should shift. And prioritising this and making it a systemic approach, not just we buy in some training or we buy in some meditation. It's more than that.
Thanks very much, Mary. That sounds very sound advice. And I mean, that story you've told about space for taking breaks, etc. We know from our work on 12-hour shifts that nursing staff were just not getting breaks. You know, I think all of that's been compounded during COVID as well. Laura, I'm sure you've got a few stories to tell there as well. Juliana, maybe this is a question for you as well as other members of the panel, because you raised the vexed question of vaccination and compulsory status of vaccination for care staff. What are your views and thoughts on this and the implications of the government aiming to make COVID-19 vaccination compulsory for care staff? What's your thought on that?
I mean, obviously that's a breaking story for today, so I don't speak for any one organisation, but what I will say, and I think it's important that we all recognise that everybody wants to be safe. Everybody wants, you know, good healthcare. So that, I think everyone's agreed on that. I think what's important, and certainly from the Tides work, is that people's concerns around vaccines, and whether that's described as hesitancy or otherwise, is something that's across the board. It's not specific to any one particular group or any one colour group. And I think what's important in terms of moving the narrative along, which is what these studies are trying to show, is that there are different influencing factors. And so we need to be a bit more targeted and a bit more focused, a bit more research driven. And, you know, where people are having concerns that could be addressed, that could actually be addressed with factual information, that could be addressed with clear, transparent, empathic responses and measured responses, then that's what we should be doing. And I think when you look at good local based public health responses, they tend to be much more targeted and focused, and they know their communities. And I think that's what we're trying to do. I think the COVID space is fast moving. And in terms of, you know, I don't work for the government, so I can't speak for the government. All I know as a researcher is that we should be you know, focusing and doing a lot more work to understand what people's concerns are. So then in another group, for another conference, when people are talking about issues around inequalities, health inequalities and discrimination, we'll understand that why we can't treat that in a silo way, that actually they do mesh. And so that's important to know.
Brilliant. Well, I'm very sorry to say, I think we're coming to the end of our time here. I'm sure there's a lot more we could discuss on that and many other questions. I just want to thank our fabulous speakers, our panel of respondents and participants, all the people behind the scenes as well. And don't forget, there's the link for NHS CHECK, and it's nhscheck@kcl.ac.uk for the emails. Do keep in touch and keep well and keep safe. And thank you so much for tuning in. Thank you.